Good afternoon, everyone, or good morning if you're joining from the US or Europe. I want to thank you all for connecting to the second day of the IAS Educational Fund and Asha Foundation Symposium for South Asia. I'm Dr. Sunil Solomon. I'm an Associate Professor of Medicine and Epidemiology from the Johns Hopkins University School of Medicine. I think many of you know in South Asia, key populations face a disproportionate burden of HIV infection. And so I really am pleased to welcome you to this third session, theme of which is bringing the focus back to key populations with a particular focus on people who inject drugs and co-infections. So this session will provide an update on advances in HIV prevention and treatment for key populations in South Asia. Discussions will also spotlight primarily challenges faced by people who inject drugs, the key population who generally tend to be left out of conversations when you're planning an HIV response in the region. You'll hear from a range of stakeholders from government and community. You'll also have the opportunity to ask them questions on how policies and practices work, personal challenges the communities face, and how can we really adapt to better respond to key populations and people who use drugs or inject drugs. I want to start by sharing some housekeeping rules. So I believe at this point in time, all participants are currently muted. I invite all of those of you who have connected virtually to please introduce yourselves by typing there's a chat box which is on the right underneath the screen. So you will see that your message shows up in the interactive box to the right of the screen. So maybe you can type your name, your last name, and the organization you work for, and the country from where you're from. I think in a real world where there was no code, we would all be interacting in person, but maybe this is an opportunity for each of us to connect with each other and get to know who else has logged on to this session. So if you are having any technical issues and are unable to see the chat box, what you can do is you can try to change your internet browser and to select the option to allow all cookies. And this will enable you to interact with the speakers when entering into the platform. So you can also use the same chat box during the question and answer session, which will take place right after the panelists have done their presentations. So you're also welcome to send comments into the chat box. The last housekeeping rule is, as an active participant of the IAS Educational Fund South Asia, you have the opportunity to receive a special IAS membership offer. If you buy a 1-year membership, you get 6 months free. And if you buy a 2 years membership, you get a whole extra year free. So to take advantage of this offer, we ask you to reach out to memberservice@iassociety.org with your request for this special offer in the membership. So we can transition now to the actual session itself, and I want to start by introducing our first speaker, Dr. Salil Panakadan, who is a senior regional advisor with UNAIDS for the Asia Pacific Regional Support Team, who's been working on HIV treatment and prevention issues, including programs for key populations and their readiness for integration into the universal health coverage. So Dr. Salil has been working in public health, epidemiology, and program management for over 25 years, and he was one of the founding members of the National AIDS Control Organization in India when it was initially being established in 1992. So he will present on the advances in HIV prevention and treatment for key populations in South Asia. Over to you, Dr. Panakadan.
Hello, good afternoon, colleagues. I'm Dr. Salil Panakadan from UNA's Regional Office for Asia and the Pacific in Bangkok. My talk today will be on advances in HIV prevention and treatment for key populations in South Asia. The talk will be essentially structured in 4 parts. I will start with a quick overview of the HIV big picture, global, regional, and sub-regional, followed by status of prevention and treatment response in the region. Then I will talk about advances that could make a difference in these areas. And finally, I will talk about the current status of these advances and challenges faced in scaling them up for impact on a public health scale. Global and regional summary clearly shows that we are about 15% of the total new infections and people living with HIV globally, which does not mean that AIDS is over, which seems to be the message some people get. And the rate of decline has not met its targets, even though South Asia is slightly better than the Asia Pacific rate of decline in new infections. As expected, the trends in new infections are diverse across countries. In the South Asian region, Afghanistan and Pakistan both have a rising rate of new infections, which is not shared by other countries in the region who have been lowering the rate of new infections, but facing a plateau in the recent past. Getting straight to the point on HIV prevention, the Asia Pacific epidemic and the South Asian epidemic is essentially a key population epidemic. What is striking is we have started prevention programs 30 years plus, and after all these years of program implementation, prevention coverage continues to be low and stagnant, less than 50% of comprehensive prevention coverage among key populations, a status that remains for the last many years. The same situation prevails if you look at the country-wise prevention targets in terms of coverage, and it is essentially time to, and that is for all key populations, and calls for new ways of looking at this problem by getting new advances, as this topic is about, and also to make sure that the basic problem of low coverage with programs is addressed by the programs all over the region. Looking at the MSM coverage rates, uniformly below 50%. Female sex worker coverage rates are better. I would attribute this mostly to denominator issues rather than the actual coverage. If one looks at testing coverage, it's again conforms to the overall picture of low coverage, ranging from around 39% for people who inject drugs to around 54% for female sex workers, and this is the regional median. What can be done? One of the ways of increasing coverage of testing is by using HIV self-test kits so that people can test at home in privacy. And what we know about the status is essentially about what is the status of policies in countries, are policies on self-test being implemented and so on. But we do not know, for example, in a centralized database, what countries have registered self-test kits, what are the costs of self-test kits in these countries if one wants to use them. Self-test kits are not the only way, not the only strategy to improve testing coverage. And for that, there are a number of other methods. We see that all these innovative approaches face structural and policy barriers, with many countries not permitting lay provider testing, for example. Another approach is pre-exposure prophylaxis for populations. We note that the first formulations were approved by US FDA in 2012, and the last 10 years, we are still in pilots in most countries. And we did not meet the targets of 2020 of putting 3 million people on PrEP globally, and we are still playing catch up. It is time to convert pilots to programs in all countries. The issue of, or the approach of virtual interventions is something which we see a lot of promise in trying to get prevention and treatment coverages higher to reach the unreached and so on. So this is an example of how social network-based approach in India proved successful in getting hard to reach MSMs. And we know that increasingly the young population, the young key populations who need our services, and they do not identify themselves as key populations overtly, and it's very difficult to get them on our location-based service delivery that we do now. Looking at drug users, the picture is that the only program among drug users, needle and syringe exchange programs, have made some progress in some countries, but otherwise important approaches like opioid substitution therapy still continue to lag behind in implementation. The recent COVID epidemic-related disruptions gave a big boost to opioid substitution therapy take-home dosaging, which is something which has been lying dormant in terms of making a decision in governments and so on. So the long pending decision in rolling out take-home OST therapy was something which was started off during the COVID-related lockdowns, and one can see the progress made in the countries. Essentially, Myanmar stands out as an example where this has taken off quite well. The challenge now is to keep the progress. This has since been slowing down and stagnating, as it so often happens. And going on to treatment. Now, treatment advances, as you can see, if you look at HIV testing and treatment cascades, the progress has not been very good. We look at coverage in countries. We still need to catch up with the targets. The late diagnosis is an issue in Southeast Asia and South Asia, and this can be addressed by promoting access and also managing stigma among others. Here also virtual interventions have a role. As you can see, the virtual case management approach takes care of or contributes to earlier diagnosis and treatment initiation and better adherence monitoring to make sure that people do not lapse in the treatment. So another advance which got a boost during the pandemic-related service disruptions was multi-month dispensing of ARVs, which has the potential to address many treatment-related issues, but face policy, guidance, and procurement-related barriers. What we have seen globally is that an efficient and predictable procurement system is key to roll out and maintain high levels of MMD. The punitive and discriminatory laws that exist in the countries of this region is a big impediment to rolling out any of these programs to take advantage of the new advances in prevention and treatment. Having said all this, finally, the big picture is it is all very well to have new technologies, new approaches, new kits, and so on, but new medicines. But unless we look at coverage, we look at reach and access to populations for whom it is difficult to access these services, new advances will remain as pilots. We need to convert pilots to programs and aim for rapid scaling up. Strategic information is crucial, and we cannot go on having these traditional ways of collecting strategic information on policies and guidelines, but also should look at collecting information on costing in countries, registration of products, and so on. And crucially, partnerships and with communities are very important in taking forward these new advances, coupled with domestic funding for sustainability. Non-traditional channels should be increasingly used to increase access, and at the same time, structural barriers that have been traditionally plaguing our programs need to be addressed along with enabling policies. Thank you very much for your attention. I stand by for any clarifications and discussions.
Thank you, Dr. Panakaran, for that excellent presentation and clearly highlighting the progress made, but also the challenges and the gaps in programming. I'm sure that poses several interesting questions the audience may have. I'm now pleased to introduce Dr. Shoguni Rajan, who's the Deputy Director General at the National AIDS Control Organization. So I've known Dr. Shoguni for several years, and she is a great friend of the community and has served in several divisions of NACO, and though she really is the Deputy Director General for Targeted Interventions, she knows pretty much most of what is happening with the National AIDS Control Program and has been one of the leaders and advocates for the key population response. And her topic, and she's going to speak to us today about the urgent need for a targeted response for people who inject drugs in South Asia. Over to you, Dr. Shoguni. Thank you, Dr. Shoguni, for that wonderful presentation and for highlighting the dramatic progress India has made, especially during the COVID-19 pandemic and its response to the needs of the key population communities.
Okay.
Unfortunately, we are having some technical glitches with one of our speakers, Dr. Saeed Hamid, and he seems to have dropped off. So we are going to move straight to the live panel session. And when Dr. Hamid is able to join back on, we'll definitely go back to his talk, because I think it's critical to discuss hepatitis B and hepatitis C, especially when you're talking about people who inject drugs, because it really isn't complete without addressing the co-infections that these populations disproportionately face.
Sunil, I'm here.
Oh, great. Ben, so maybe we go straight. So maybe Dr. Hamid was able to join back on, so we will definitely go back to the talk. This is just to keep the audience. I know like it's in the afternoon post lunch, you're probably tired, but this is to keep it exciting for you that we try to move things around. But anyway, so welcome back, Dr. Saeed Hamid. He's a regional he's from the Aga Khan University, and he is going to talk to us today about hepatitis B and hepatitis C co-infections and the need to urgently address this in the region. Over to you, Dr. Hamid.
Okay, just let me try and share my screen, Sunil. Can you see my screen now?
Yes. Yeah.
Okay.
Perfect. Thank you.
Okay. Well, thank you very much, and sorry for these glitches. I'm actually out of my station running another symposium, and therefore it was tough to get to be two places at the same time. So my apologies. Anyway, just to move on quickly so that we don't waste time. We know that the global status of hepatitis C infection has recently been re-evaluated by the WHO, and it is now considered to be 58 million people infected all over the region, with 1.25 million new infections each year. Can you hear me all right? Sunil, am I audible?
Yes.
Okay, thank you. Okay, so shown on this slide is Pakistan's place in the viremic burden for hepatitis C, and we are second to China, just because of the fact that China has a much larger population than we do. We have a higher prevalence, and therefore probably the highest burden at the moment, after now that Egypt has treated its hepatitis C infection. The sad part is that our prevalence rates for hepatitis C are increasing over time and not decreasing, which is really an eye-opener for us. For example, if you look at our side of Punjab, we were at about 7% in 2008, and in 2020, the latest survey, we are up to 9.5%. So a 2.5% increase over a decade, which is really quite a demoralizing situation here. Sindh remains static, but I suspect this is not very good data. The other provinces have also increased. So overall, we have gone up from a national prevalence of 5%, which we thought was the best study at that time, to 6.5% overall national prevalence. Now, coming to the HIV, the HCV co-infection burden in HIV patients, I think this is one of the best systematic reviews and meta-analysis that I've been able to take out for the moment. And this appeared in Lancet Infectious Disease in 2016. So it just shows that the differences being that in South Asia and Southeast Asia, the highest numbers of co-infections are actually in the pivot population. So up to 83%, and there are other data to support this, 83% of our HCV, HIV co-infected are 83%, are as high in the high 80s, simply because of the fact that these are mainly transmissible through the injection drug use and much less frequently transmitted through sexual transmission, for example. So that is the key here. That it is, and if you exclude pivots, you can see that is only about 3% of the total population, which is HIV, HCV co-infected. Now, we all know that HIV, HCV co-infection or HIV in an HCV infection in an HIV individual does lead to adverse outcomes with liver disease. In fact, liver disease is one of the biggest killers at the moment, particularly in people who are well maintained on ART therapy. So shown in this slide are the differences, the green line being the one which is co-infection without effective HIV therapy, and that means greater than 1,000 copies per ml of HIV-1 RNA, as compared to HCV monoinfection or as compared to reasonably controlled HIV infection. The same goes for if you look at CD4 cell counts. Again, the green line being the one without effective HIV therapy, in which the CD counts are more than 10 to the power 9. There is other data to suggest, other meta-analysis to suggest that end-stage liver disease, as I said, actually with good control of HIV and prevalent ART therapy, the bigger issue is now liver disease with decompensation liver disease being the highest risk for mortality. This data was interesting. If you look at the presence of hepatic steatosis, the odds ratio of having more steatosis as compared to people who are HCV monoinfected, for example, was to the order of 1.61. And that also means that it will not just be the co-infection, but also the steatosis that will drive liver disease. So liver disease now makes up a good chunk of deaths that we know will occur due to this. The saving grace for our region in general, and particularly for the subcontinent, is the fact that we have now very cheap, we have had very cheap DAAs available, generic DAAs available for quite some time now, since January 2017 in Pakistan. You could get a full course of Indacta for a month's course at 30 per month. It is now a little bit more expensive since the pandemic, but still the prices are very, very nice. We also know that HCV DAAs work as well in HCV HIV co-infection as they do in HCV mono-infection. And particularly important for us, I think, was this study, which showed that SOF and DACLA combination, which is by far the biggest combination that we use for our HCV mono-infected patients, would work as well in HIV HCV co-infected patients as it would in HCV mono-infections. In HCV mono-infections, we have data to show that a per protocol analysis, we can get upwards of 95% of sustained virological response, and that comes not just from the Pakistan side of the equation, but also from the Punjab program, which has extensively used SOF and declarasphere and have obtained those high results. So this was the LA2 study, which was a phase 3 multi-center open label study. It had genotype 1, 2, 3, 4. In particular, genotype 3 is important to us because 70 to 80% of our genotype in Pakistan is genotype 3. And these were treatment naive or treatment experienced patients. Here are the demographics, which was really not a great deal of difference. But you can see that for genotype 1, very high results, and even for genotype 3, there were very high results with basically 12 weeks of therapy for SOF and DACLA. So that is helpful. So what are the treatment parameters? All persons with HIV should be treated with potent ARTs, especially those with HCV HIV co-infection. HIV co-infection is independently, as we know, associated with HCV disease progression. And the second caveat is that HCV treatment should also be a priority for persons with HCV HIV co-infection because the adverse events are similar and the results are fantastic, except that we need to be aware of drug-drug interactions which are the one which are extremely important. So what are the common scenarios that we quite often face as practitioners when we are asked to do this in people who are HIV positive? What do you do with persons who are taking ART with the HIVs are in suppression, who plan to initiate HCV-DA therapy? We need to be careful about selection of the DA regimen, just to be sure that there are no drug interactions, as I said, and there may need to be an adjustment of ART to facilitate a specific DA regimen. Patients not taking ART who plan to initiate HCV-DA therapy, the question is which infection to treat first, or do you start both simultaneously? So these are some of the guidelines. For many patients, initiation of ART should be prioritized. However, HIV treatment and HIV suppression are not required before HCV-DAs are started. Treatment readiness for 8 to 12 weeks of HCV-DAs may be different than for lifelong ART. HCV treatment and cure may serve to facilitate HIV care management, this is an important point, particularly when we're talking about pivots, that this may facilitate further HIV care. SVR will certainly, hopefully, reduce the risk of drug-induced liver injury. If ART is initiated first, consider delaying DAs 4 to 6 weeks to confirm tolerability of the ART and the HIV RNA response, although this is not entirely necessary. I will not go through the details of the interactions. These are very well available on various websites, particularly the University of Liverpool website, which has just recently been revamped, and it is a very much more friendly website to use that I could see. Please consult these websites or other means that you have to make sure that these interactions are well known. As you can see, they're mostly with drugs that we don't use normally in the subcontinent, both in Pakistan and I believe in India. GP is not really very easily available, and Drizosopir, Elbesivir also has a limited use. Co-administration of lead or well with TDF but not TAF requires liver monitoring of some sort, but that is about it. This is just in a nutshell, an HCV care continuum: diagnosis, linkage care, treatment, cure, persons at risk for infection, counseling, harm reduction. But please remember that the advanced stage 3 to 4 fibrosis people need continuous counseling, continuous harm reduction, and surveillance for HCC. That is important. And you would survey them normally as you do with a HCV-borne infection, which is every 6 months with an ultrasound plus minus a alpha-fetoprotein level. Now, there is some concern about HBV reactivation when we treat with HCC-DAA, although this seems to be more of a theoretical concern than a real concern, because the incidence is so low that really I don't think we need to bother too much about this. Just a few words about HBV, HIV, which seems to be a little bit less important because the drugs are so many of the drugs are common. Serological evidence of previous exposure to HBV is found in more than 80% of HIV positive patients, with considerable variation according to the geographical regions. And I suspect that in fact, our data from Pakistan also shows that about 70% of our HIV pivots have evidence of some previous exposure, not active disease, but some previous exposure to hepatitis B. HIV concurrent infection influences the natural course of HBV infection by impairing both the innate and the adaptive immune responses. And therefore, this leads to higher chronicity rate and decreased rates of spontaneous conversion, seroconversion of anti-HBe, and also to anti-HBs. The levels of HBV replication are increased in HIV-infected patients and those who are active. And this, of course, causes more rapid progression, higher rate of decompensation, although not good data about higher incidence of HCC, but there is certainly the risk of liver-related mortality, which increases with HBV-HIV co-infection. Sorry, my slide is not moving. Okay. This is just a little bit of data from Pakistan. I was suggesting out of 650 HIV patients that were tested, 12 had co-infection with hepatitis B, 63 or 80% had co-infection with overall, 12 had co-infection with viral hepatitis. 63, 80% of these had co-infection or evidence of past infection with hepatitis B virus infection. And of course, here, the sexual transmission was the most important one. For hepatitis C, the figure was 19.23%. But as you can see, the large majority are IV drug users. They are elder in age, mostly males, both for B and C. But the B ones, much younger, less than 30 years of age. And this is data from, again, from our Punjab province that we're looking at. So what about managing concurrently infected patients?
The end of time, can we wrap up quickly? Thank you.
Right. So we know that selecting a regimen is not difficult, because if it is generally these regimens contain tenofovir or both tenofovir, dipivoxil or TAF, and if not, then basically you just change to entecavir, which should be effective with a 3-drug regimen. So that is the end of my talk. Thank you very much for your attention.
Thank you, Dr. Hamid. That was perfect timing. So we will move now really on to the panel discussion versus going back and forth. And we have a very interesting panel today. We have 5 speakers who have varying levels of expertise who could definitely discuss this response. Our first panelist is Celeste Lima Pokam, who is from Imphal, Manipur, and she currently works as a case manager at YRG Care. Dr. Ajit Karavita is a consultant venereologist at the Sexual Health Center Teaching Hospital in Anuradhapura in Sri Lanka, and he's the head of the Provincial Health Training Center of the North Central Province. Mr. Salman Qureshi is a senior director at Nayi Zindagi Trust in Pakistan. He has vast experience in designing HIV interventions for key populations and has been an expert in translating evidence into action. So he's played a really pivotal role in successful Global Fund HIV grants for people who inject drugs in Pakistan. And he's also been responsible for providing strategic guidance to comprehensive HIV programs for PVED and their spouses over 58 districts of Pakistan. The next panelist is Mr. Anand Grover, who probably needs no introduction for those of you who have been working with HIV in the region. He's a designated senior advocate practicing in the Supreme Court of India. He's the director of the Lawyers Collective. He was a UN Special Rapporteur on the right to health at 2018 and 2014. He has done several leading cases on HIV, drug use, same-sex relations, issues, female sex workers and male sex workers face, and a host of other human rights issues. And our last panelist is Bibo Haider. She is a development professional who has been working with sexual and gender minorities since 2010. She's currently working with NAS Pakistan as a drop-in center coordinator at the Lahore Larkhana community-based organization. Her approach towards sexual and gender minorities is loud and proud. She raises her voice for the trans communities who face several problems in Pakistan. She has participated in several national and international level consultations on hijra and other sexual gender minorities who exist in Pakistan. She is also the president of the board of the Subran Society and a member of the National Transgender Task Force team, work against violence and harassment. So welcome you all to the panel. So I'm going to start off the panel with some questions for the panelists, but we are really looking forward to questions from the audience. So both the panelists and the speakers, everyone is going to be available until 4:10 p.m. India time. So Celeste, we want to start with you. And I think as you have come out and told everyone that you really are a woman who injects drugs in the northeastern states of India, we really want to get your perspective on the current response to people who inject drugs in India. I think Dr. Shoguni went over a lot of that, but generally these programs are tailored more towards the male population than the female population. So we would really love to hear from you, like the way the PVED program is currently designed. What do you think works? What doesn't work? And what needs to be done to really address issues women who inject drugs in the region face? Over to you, Celeste.
Hmm. First, my perspective in this is that uh, uh, the society doesn't accept us, uh, women who uses drugs. We face many discrimination, stigma, and all. Uh, Male do face stigma and discrimination too, but women mostly face more of them. So the current response to people who inject drugs right now, from my perspective, is that um, it depends on the society. From my perspective, I think the society should understand that it is a disease, okay, and anyone can have it. It is a disease, and uh, for female users, there is so many discrimination here in Manipur. We have, uh, I mean, in Manipur there are like uh, we can find drugs everywhere in here in Manipur. So many people, females are youths are starting to use drugs, and most of the uh, women who doesn't have money to use drugs and all, they go into prostitution to earn money. That's the easy way to earn money. So they go into prostitution, and that's the main reason for like getting infection like HIV, hepatitis, and all this infection. And what I want to say about what needs to be done is that if we don't have many facilities in here in Manipur or India, I don't think we don't have many facilities. For guys, we have many facilities. We have many rehab centers. We have uh, many facilities in here for men. For female, we don't have many facilities here. If we want to get better, if we want to get clean, we don't have many facilities, so we don't know how to or where to get help from. So I think we need to advocate to the government that we need more facilities like rehab centers, more counseling, uh, more counselors in the schools, and most important is that the society should understand this. The society doesn't. We should give more awareness to the society. They don't accept this, so the root cause is that if the society doesn't accept us, then that is the main reason. Even buying, from what I heard before, they talk about that the syringe exchange program. From what I heard about is that for women, we can't go in there and take syringe. I know they give free syringes, but we can't go there and take free syringe because of how people will react, how people will judge us, like that, and all the discrimination and all. So we go and buy our own syringes. Even that small matter, it's hard for us. So if we don't have the syringes, some of the pharmacy doesn't give us syringe. So our only option is that we use it from a friend. They use syringe. So sharing needles like that, that from that can cause infection, many infections like that. For me, from my perspective, I think it will be better if if the society get more awareness of this, and the government should help us to have many facilities for women, not for men. For men, we have so many here. For women, only 3 of rehab centers are here in Manipur. Only 3 of them. That also they don't work in proper way. They don't. I've been there, bought 3 of them, but that's not how they treat. They should. I don't think they understand how addiction works. They are just rehab center. We just go there and stay and come back again, and we get into the drugs again. So I think the government should help us uh, get more facilities about rehab centers and all about that. And the society should be aware that it's not only a disease that it's not only the user's disease, it's a family disease, it's a brain disease.
Thank
That's
you.
what I want to say.
Thank you, Celeste, for really highlighting that important point, which we tend to forget that addiction is not something that many people do by choice, but it really is the disease that
Yeah.
needs to be treated like any other disease, and also the unique issues related to stigma and discrimination that communities face. And I think there's definitely an opportunity to address some of these issues in a larger panel. But in the interest of time, so let's move on to Dr. Ajit. So Dr. Ajit, we really don't hear a lot about the HIV epidemic among key populations in Sri Lanka. So can you tell us a little bit more about what the situation is with key populations in Sri Lanka, and what is the government's response to the HIV epidemic in these populations?
Okay, thank you very much, and hi everyone. So I'm representing the government. I'm Dr. Ajit Karavita, and a consultant venereologist who is looking after HIV and STI medicine in the country, as well as the prevention and program sciences. So in our setting, so the Sri Lanka is a quite an island country and closer to the southern tip of India, you may know. So the population is about 22 million, and
Looks like we have another technical glitch. So Salman, I'm sorry to put you on the spot, but we're going to jump straight to you and come back to Dr. Ajit when he joins. So Salman, thank you again for joining. I think Pakistan, as we all know, has several challenges, including a lot of legal issues combating the HIV epidemic among people who inject drugs. Like, for example, issues with access to harm reduction services. So in a country like Pakistan, where you have such big impediments to efficient program and service delivery, what do you do, and how do you think that we as a global community could do? Over to you, Salman.
Hi, Sunil. Thank you very much for giving me this opportunity to speak here. I mean, in Pakistan, the HIV response among PIVOT, I think, is one of the positives of HIV response in country. And so harm reduction services are there consistently since last 10 years and have been scaled up to 58 districts now with the, I mean, mainly needle injection program, and which is, one of the only prevention effort that we can do in terms of harm reduction, because OST is not there. So in terms of geographical coverage, I think we have reached almost every single place where we have reported injecting drug use and HIV among people who inject drugs. So, and we reach almost 8,000 people every day with clean needle syringes, and that follows up with HIV testing. And, almost everyone, more than 90% of the people have been tested out of 80,000 that we have registered. So, the problem remains when it comes to putting them on ART. And maintaining them on ART. Otherwise, in terms of coverage, I mean, we do not agree with the figures units normally come up with, and we have contested those also. I mean, and we can never reach to those expectations of the national estimates driven from the Asian epidemic modeling, which are far too high, and will still remain at the bottom of the table. But the reach is quite high. I mean, we reach 36,000 people, which in our view are quite a big number of people who inject drugs in Pakistan. And we do it with mobile outreach. So the outreach workers go out and meet them at 520 hotspots across 58 districts every day. So we meet almost 8,000 people every day who get clean syringes. And out of those who are HIV positive are linked up with ART services. The process is on. We do have the gap of OST, which we are trying to fulfill with taking them to a residential ART urgence unit where we treat them first for drug use for 1 week, and then move on to ART initiation so that they continue, they're likely to continue it afterwards. So in terms of range of services, the spouses services for the spouses of HIV positive PWID is also one of the hallmarks of this project, and we have reached 4,500 spouses, and we have found out around 600 who are HIV positive already, and we are trying to link. I mean, all of them almost have been linked up. And then we have a rigorous follow-up adherence monitoring to actually make sure that the services reach to them, and that we have a MIS which captures every single contact between a staff and a client, and we can see the trends of dashboards are available to see whatever happening in the field very clearly. We have recently initiated the point of care viral load testing for people who are on ART, and we have recently started, and we'll share the results very soon. The missing element is Hep C treatment, which Dr. Saeed has quite rightly pointed out, and we are working with him to actually make sure that that reaches to people, because majority of PWID who are HIV infected are co-infected with HCV, and even those who are not infected with HIV are infected with hepatitis C. So, and the treatment is almost negligible, and we are trying hard to get that going. And there is also a light at the end of the tunnel for OST in some recent consultations that we might find way to introduce opioid substitution therapy also in Pakistan. And during COVID, since most of our services are outreach, and we go to the community rather than waiting for community to come to us, so there has been hardly any disruption except for the severe lockdown during the months of May, June, July of 2020. Otherwise, we have been able to manage all our services quite the same way that we used to do, except that at some times we had to lesser the frequency of field visits, but providing services for the rest of the days for which we will not be able to go. So this is the situation here in terms of the major missing elements are OST and hepatitis C treatment that we see as of now. Thank you.
Thank you, Salman. I think that really does highlight the need for OST, because it's generally, OST has been shown to improve adherence, reduce a lot of other things besides just harm reduction. So I think that is a critical component we can talk about later. So we'll move on now to Anand Grover. So Anand, I think you have been involved in the legal aspects of HIV in India more than anybody I can remember, at least definitely over 2 or 3 decades, probably right from the beginning. So I think one of the challenges when working with key populations in India is or in many countries globally, is you're oftentimes dealing with behaviors that are criminalized. So how do you think we can actually thread the needle between what is criminalized, but at the same time being able to deliver services? And from a legal standpoint, do you think there are any reforms that could actually help accelerate progress towards HIV epidemic control in the region? Over to you, Anand.
Well, Sunil, you're asking very big questions, and they have to be answered. I'm glad Dr. Shoguni Rajan is here, who's been a key support person in NACO. Some of the issues that are arising are to be dealt by them. Now, I think we have to go back to the drawing board in this sense, because HIV actually really required us to probe into criminalization of not only drug users, sex work, same-sex relations, etc. Now, we have succeeded in some of them. Same-sex relations in India are now decriminalized because of the litigation we launched in 2001 and achieved a positive result in 2018. Sex workers and drug users have not had the same success story. As far as sex workers are concerned, the unfortunate thing is that they were the key element. Sorry to take you around outside drug use, but it's very important because they link up. Sex workers were the key strut, as it were, of the program to impede the transmission of HIV. And it was because we were able to empower sex workers to change their behavior, to be able to negotiate condom use, that we were able to stop the transmission in large parts in India. With full support of every sector of civil society, government, and international programs. But in drug use, it has been much more difficult. All these areas have been heavily stigmatized and criminalized because of the British and the Western culture. So one of the things we have to start talking about is that in our region, the culture was not to criminalize. For example, whether it's same-sex, drug use, or even sex work, we have to say that our culture was very different. But unfortunately, sometimes what happens is, and these are, I can't explain them, but like Aryan Khan's case recently, he didn't even have any drugs. And there was such a lot of, on television. And that showed the prejudice of the media, everybody. And ultimately, what happened? There's nothing, there's no case at all. But the frenzy that was actually developed by the NCB is so unfortunate. It impacts on our work. So we have been trying to advocate that it is very important to destigmatize these behaviors. The persons who actually imported these laws into India and through the war of drugs and the 3 drug conventions, they've decriminalized. In the US, cannabis use is decriminalized, but we are following their mentality. What are we doing? Are we Indians or Pakistanis or South Asians, or are we actually following the Western mentality? We have to get our act together and say this is not part of our culture. So decriminalization, and that's what Celeste actually raised the very big issue. Why are drug users treated the way they are? Because of the British laws and the inculcation in our society of British cultures and Western cultures. Drug use is actually not prohibited or criminalized in our ancient cultures. So we have to get that straight. In terms of the law on drug use, etc., we have not been able to decriminalize. That should be the aim. So I am on the Global Commission on Drug Use, which is actually personneled by all ex-prime ministers and presidents. And all of them invariably say it is high time that we started to decriminalize drug use and possession, because the persons who use them, who are dependent, are not criminals. So this issue has to be taken head on with everybody. The law actually has not been changed in terms of the NDPS, narcotics, drugs, and psychotropic substances. But we were able, through the HIV movement, bring into force the HIV Act. The HIV Act actually doesn't allow criminalization of services being provided. There's a special section within the HIV Act. Suppose like you have needle syringe exchange programs. Earlier, they were criminalized, but we made sure in the HIV Act, any services, whether it's promoting condoms to sex workers or gay men before 377 was read down, or actually needle syringe exchange programs, they are no longer criminalized. There is a safe haven. But we still have to move forward and make sure that we start decriminalization. But for that, I think we ourselves should believe that drug use is not harmful. Why I'm saying this is cannabis, and let me say it very straight. People will say I'm committing blasphemy. Some of, even our people. Drug use, cannabis use is not harmful.
You know what is harmful? It is alcohol. This is the studies. I mean, I can give you a lot of studies. Sunil, you know better than me. But in the beginning of the 19th century, the British actually did studies and they said, you know, heroin is not as harmful as alcohol. And those studies have been validated, revalidated. But we still keep on believing what the British moral Christian preachers told us. No, because Indians and Pakistan, now Pakistan, Indians in the old days, those brownies used ganja and cannabis, they are uncivilized. Or Bolivia, they use coca. They are not harmful. I mean, yesterday was Holi, Sunil. You know how many people take bhang in India? It was very good for you. My father-in-law told me that when he doesn't take bhang, he can't even eat one rasgulla. But if he takes bhang, he can have 10 and he doesn't have diarrhea. I'm putting it straight. I'll say this before the Honorable Prime Minister because I know he is a person who can make changes. He should know about these things. Unfortunately, I don't know whether Dr. Shoguni Rajan has the access to say these things. But we have to say this straight. And I think Celeste is a good person who can actually move forward and become one of the leaders in Manipur. I also agree with her that the men have dominated the discourse. My good friend Loon Gangte is very good, but unfortunately he's a man. So Celeste should come forward and make sure that women actually come and say what I have said, that if we use drugs, there's nothing wrong with us. We are at the most, we have some illness which can be remedied, but there's nothing wrong with us actually. People are using alcohol every day and they're not only, actually being violent with their families, but they actually kill people on roads. They are much more dangerous, but nothing happens to them.
Thank
So we
you,
need to have
Anand.
influence. Thank you.
I think we'll move on, but I think it's clear that I know more. I'm a drug user and an alcoholic based on what you've said out
Yes,
there.
I'm a drug user. Absolutely.
So we'll move on to Bibo at this point. So Bibo, thank you again for taking the time to join this panel. I think one thing we as program designers or individual governments generally tend to do is like we put people in buckets, like either HIV or TB or viral hepatitis, or based on like behaviors in MSM or trans or PVID. But I think at the end of the day, what we forget is we're all people, and people generally fall into multiple buckets, and these programs generally aren't designed to address all these multiple issues that people face. Right? So as a loud and proud trans woman who also uses drugs from Pakistan, we would love to get your personal perspective on how do you think programs should be designed to really affect people versus the labels that we attach to people.
Hello everyone, it's me, and I think people they know about anything. They just label on myself and other cells. They are just users. They are not supposed for us. That's it. No, I am using, and I feel like I'm tempted because where every time, many times you know we are traveling community in isolate also all things. We have a move forward to using the drugs and having the HIV disease, all things. But people, society not supporting us, not connected us, not very. It's a big stigma in Pakistan. Like drug user is not a good person, and the community, society, and community does never support to anyone. They're using to drugs. They also use, but they not what we use it every you use every. I'm using that one thing one time. That's it. I'm not using the many things on one time. The second thing is people having the HIV problem, and then after that they are very disturbed and use their drugs, and we don't have any rehab center, we don't have any supportive center, and community not supportive to other communities, society every time level with us. So I think it's not bad thing, but people not clear mind. They not talk about the all things. They just see and talk. They not that think about what he is done, why he's done. No. And second thing is government has done the all things is good, but government is government. I believe on myself. So I love to be raise voice of community because I'm going to any side and taking the listening the people's notes and the all things, but I'm just saying no. I am a human and I know who I am. No, don't tell me what I need to. So that is Pakistan is all things very good, but community is not supportive. Society sometimes is very level to us. So this is a very bad thing and not rehab centers. So that's why it's big problem. Nothing else. And child um, now these days in Karachi is using the many net of that drug and it's very cheap thing, but it's a quality thing. Many people just used for sex, many people use for enjoy that and child they, they are not frustrated about the families and studies. They go in that side and using the drugs and those are all things.
Thank you, thank you, Bibo. We will move. I think we'll rejoin, so maybe we'll move on to Dr. Ajit.
Okay, thank you. Very sorry for the disruption. So I'm representing the government of Sri Lanka. So your question was to ask about the key population response in Sri Lanka. So Sri Lanka can you hear me? Like in India. So then, so we are working as a government Ministry of Health, and under which we have the National STD and AIDS Control Program. There again, we have about 50, around 50 network clinics in the island covering
Ajit, maybe you can try turning off your video. Maybe it's like a bandwidth buffering issue.
the KP interventions in different parts of the districts. And also at the center, we have a director National STDs Control Program, and as well as the national coordinator to look after all the KP interventions in the country. So therefore, so that is the network. And that is the infrastructure in, controlling the KP activities and KP interventions. So therefore, so in the structure wise, we have the national program as well as the district clinics, and through which there are KP units where they conduct different programs. But there's another national AIDS committee and also the subcommittees and the district level committees as well as the provincial committees to give guidance for all these activities. And the next thing is that this we cannot do alone. So it is not only the government-led program, but the government is giving technical advice and guidance for these KP interventions. So there are lots of organizations, the community-based organizations and NGOs who are working with us in close collaboration to provide these services for key populations. MSM, FSW, transgender women, and prisoners, and beach boys. So these are the groups that we are dealing with in different prevention programs. So usually the Global Fund is providing financial support to conduct all these programs, and we are using different techniques. Some are drop-in center-like interventions, and some are like the delivery of service packages like STI knowledge, HIV knowledge, condom promotion and condom demonstration, and then the testing. So we have oral Aura quick test, and we can do self-testing and assisted self-testing, and also the rapid test. Those are available for these populations, and there are standalone websites where they can ask for testing. So testing services are provided through that. So therefore, the NGO sector and the community-based organizations are giving a bridge between the government and the accessing of this key population in providing services. So these services are basically supervised at district level and the provincial level, as well as at the national level. Through there's a SIM unit and strategic information management unit, where they all take all these data and analyze and give projections and how to work. So we are working for different aspects to give all these possible services for the key populations. So basically, then we have a networking and identification of new cases, and we are also using some partner testing. And if I consider some injecting drug users in Sri Lanka, the estimated number is about 2,800, very low number, and HIV prevalence is very low. It's less than 0.1%. So only a handful of patients are there in Sri Lanka with HIV and the drug users. But there's a issue here. So we did a study very recently, which is a consecutive sample, but the hepatitis C prevalence was 30%, 35%. So that is an issue. So we are looking at that, and we are trying to make some proposals to control that and start the treatment. We have not started the treatment, and also we are thinking to implement the pharmacological, that is called the evidence-based pharmacological interventions to go for a buprenorphine like thing without saying the replacement therapy or something, because it is not allowed in most of the agencies in Sri Lanka. So we have so that is important for actually treat people with hepatitis C. So that is a big issue, and we need to have a very urgent attention. And comparison to the South Asia, so Sri Lanka is a very low prevalent country. HIV prevalence is 0.02%, and we have sex workers about 30,000 and 40,000 MSM. Transgender women is about 1,500 like, and drug users may be 100,000 or 90 to 100,000, but injecting drug users are like 2,800. And out of that, the prevalence is very low. So we are in a very low prevalent situation. But still, we have some areas which we need more attention, especially in the co-infection. See, hepatitis C infection in injecting drug users. So those are the quick stats about the Sri Lanka. Thank you.
Thank you, Dr. Ajit. So I think we have about 15 to 17 minutes left, and I think there are a couple of questions that have come in. So we'll try and do like a rapid fire and get responses within 2 minutes. I'll start back up with Dr. Salil. I think you addressed several interventions and strategies in your presentation, but I didn't hear much about the newer strategies like the long-acting prevention, the long-acting treatment, the dapivirine ring. So where do you think these novel or these new intervention strategies fit into the response in Asia, especially for key populations?
Thanks, Sunil. I'll be quick. My entire presentation was on the theme that there are new advances, but that is not enough. It is just the beginning, and we don't seem to move much beyond beginning, even after 10 to 15 years of implementing certain things. Dapivirine ring, yes. Long-acting antiretrovirals, yes. We support them. But then, what about the pill that is used for PrEP, the most accessible, cheapest generic formulation that are currently available? There is no country in this region who has made them part of the national program. Pilots continue. So there are various reasons. One is, if you're asking for reasons, is the very visibility, the importance, the profile of the AIDS response is not what it was 10 years, 15 years, 25 years, 30 years ago, when we used to call the civil society, community-based organizations, the government used to call and tell them how to make proposals to get the money that the government used to give. to implement programs. We have moved away from there. This is one of the many programs, and the profile has gone down. That is the main reason I would think where a lot of new recent advances are just dead. They are not moved beyond pilots. The second thing I would think is cost. Now, no national program is willing to take on additional costs for the recent advances in prevention or treatment. And that is unlikely to change soon. And it is for us, I suppose, to think pragmatically and think of non-traditional ways to improve access, like reviving social marketing. It was at one point of time a great move with condoms, but then we don't see much of it. We don't see social franchising of services. So we need to think differently. And finally, I would think the reason for this kind of state of affairs is our approach, donors, international technical agencies. We seem to be happy with pilots, writing papers about the wonderful success that these pilots bring about, and so on. We are not really pushing hard. We are not talking enough to governments to create alliances to make sure that these undoubtedly great advances are available to people. It's accessible, affordable to people who need them. I will stop there, Sunil, for the moment.
Thank you, Dr. Salil. So we'll move on to Dr. Shoguni. So Dr. Shoguni, I think Celeste brought this up, but we also know that there's like a big issue with adolescents and young boys and girls who are getting into either drug use or high-risk sexual practices. So how do you think we should plan a response? Because there are these issues around consent and the legalities, which I think Anand had also talked about. So how do you address or design programs for adolescents who are getting into drug use or other high-risk sexual practices?
So thanks, Sunil. It's a very pertinent question. In terms of adolescents, there are multiple stakeholders within the Indian scenario who are dealing with various programs for adolescents, and HIV/AIDS control is one of them. So within the health system, we have a program for adolescents, which is the RKSK under the National Health Mission. And we also have interventions from the NCPCR, which is the National Council for Protection of Child Rights. And that is an autonomous organization under the Ministry of Women and Child, who is also taking up this agenda of young people and drug use. And in addition to that, we have the Ministry of Social Justice and Empowerment, who are also working on the demand reduction piece, where their focus is on young people. So in terms of reaching out to vulnerable young people for the HIV program, NACO will perhaps have to engage more with all the line departments. And what NACO can focus on for adolescents is that at least start taking into effect the adolescents who are already HIV positive. And through them, by tailoring a package of services for them, through them reach out to the ones who are vulnerable. And I think, Sunil, you will agree with me that in the Indian context, finding HIV is like finding a needle in a haystack. So if we were to take up the agenda of adolescents very broadly, it is going to be very difficult for us to find those who are vulnerable and into high-risk sexual behavior. So I think the approaches that you all have helped us out with, the social network and the peer-led approach, is what is going to help us to go there. And it is certainly a very important area where under NACP 5, the government is committed to work towards. I'll end there.
Thank you, Dr. Shoguni. So we'll move on to Dr. Saeed Hamid. So there was a question from the audience about HIV being a very weak virus that may be transmitted in the air. So Dr. Hamid, can you talk a little bit about the transmissibility of HIV, hepatitis B, and hepatitis C, and how do they relate to each other, and what modes of prevention do we have for each of them? You're muted, Dr. Hamid.
So if you look at the strength of transmission and keep the needle stick injury, for example, in your picture, So the most transmissible, of course, is hepatitis B, particularly the ones that are E antigen positive with high viral loads and so on. They are the most easily transmissible. Next comes HCV, and the last one is HIV, as you know from the literature. So the transmissibility is there, but certainly HCV and HBV are higher than HIV.
Thank you, Saeed. So we'll move back to Celeste. So Celeste, I think you highlighted several issues, and I think we have about 7 to 8 minutes left. So if we said that you have the power to make one change, like one thing that you can change about the way the program is currently, what is that one thing that you would want to change about the way programs are currently structured for women who inject drugs?
I don't know about it, but one thing I want to change should be the society mindset, because everything starts from the society. The root is a society, the main cause is a society. Okay, that's why if I were to change one thing, then I would change the society mindset, and I would give more awareness. And even in school also, I would like them to have a counselor in school, church, and all those places. I would like them to have a counselor, a proper guidance, who can tell them what is a disease and what actually it is. That's all.
Thank you, Celeste. I think you make it sound really simple, but it's such a complicated issue. So I actually want to move to Salman now, because he does a lot of this in the communities. So Salman, can you talk about how do you actually go about changing society's mindsets? I know you have extensive experience working in all the districts with communities, their spouses. How do you actually change mindsets? Because that is a very, very critical point on acceptance.
Yeah, thank you. The main thing that we have learned over this time, is like walking with them, the person who is being discriminated or the person who is being stigmatized, is the most effective way of understanding that what kind of stigma and discrimination they face. So we have associated staff to actually accompany our clients to whatever services they are supposed to get, and that is a barrier that we are usually, as a person to deal with the rest of the things, so that the person who is getting treatment should focus on what they are. So we have a social mobilizer, for example, when they go to ART centers. So he just accompanies them, take them there, get them registered, get them the medicines issued, and bring those back. So that's one model is there. And then what we have been able to develop is the district level ownership of all our services. So we have established district AIDS councils in most of the districts where we are working, where the deputy commissioner of that district is heads this body, which is properly notified, and we are also co-chair, and then we have different segments of society participating in that, which includes especially police department, because that's the main barrier most of the times when you start delivering services on the streets. So the district police officer, district health officer, and some community leaders and political leaders even. So and try to bring in the people who use drugs also as part of that group, which meet quarterly to review our progress and also to show what we are doing. And we have seen ownership coming from the district authorities to provide better services to the clients. So these are the two key information that I want to discuss. There's much more which we can discuss at some other point in time. Thank you.
Thank you, Salman. So I want to next move over to Bibo. So I think, Bibo, you mentioned several issues, but I think one thing that I haven't heard mentioned too much on this panel is the issue of mental health. And I think depression and all these other mental health issues have been a huge challenge in delivering services and even sustaining services in key populations. So what do you think is the role of mental health interventions in terms of HIV prevention? Because there is a lot of evidence that shows that poor mental health status and depression is associated with higher risk behaviors. So what would be your take on mental health services for key populations? I think you're muted, Bibo. Bibo, you're muted. We can't hear you.
It's first thing is you just depression. The all things is first the person who is targeted, who is labeled. You just talk with him and together sitting. What we have a problem, what he think about yourself and other self. You just need to talk. The first thing, you just talk to community, go everywhere, and you just see the person is in depression. You just go and talk to with her. Here, he's listening, comfortable with you. He's smiling. He say no. One of person is listening me. So I think it's good for it. The first thing is you don't labelize and don't set around the person. You just go and talk with person what he problem and what he do for you. Just to talk with people, not just many people they go and like see they're not talking with anyone. So maybe that I want to be changed in Pakistan that is a job activity because it's space for community and the mental health is connected with all things because I don't have any resources, I don't have any job, and I don't have any shelter. So I'm go to the all things. The first thing is just so government is doing good, but not our level because we need more things. So I think we are going to government and we are going to society and sitting together and the consultations of things, all things that is better thing. And we need our space and first our space.
Thank you, Bibo. I think we'll do one last question, and I think we'll end with Mr. Anand Grover. Please be very brief, Anand. I think the last question, we wanted to save it for you because we wanted the best for the last. So I think a big argument a lot of people make is when you decriminalize things, like if you start giving syringes to people, people are going to inject more. If you decriminalize prostitution, people will go to prostitute more. So this is a common argument that's used. Not only in India, even in the US it's used, and I think you're aware of it. So how do you actually address that from a policymaker standpoint?
Well, we have to go on evidence. We can't go on persons, reactions or out of the top of their hat. The evidence, and there's good evidence in Portugal, for example, where they first decriminalized, they found that in fact, there were not any case or any surge in the number of people using drugs or committing crimes. In fact, it was the other way around. People were able to secure help, they were able to behave responsibly, and they were able to actually integrate themselves in their families. As you know, a lot of the drug-dependent persons, and especially if they're on so-called hard drugs, that's another pejorative thing. What is the meaning of that? But in any event, persons who are opiate users in Punjab, in India, for example, where there's a fairly good system now, not fully up to the mark because of availability and accessibility. What is happening is that because a person actually starts becoming drug dependent, they start actually leaving their jobs if they have jobs, and then start stealing from their families and commit crimes. Whereas if you actually start decriminalizing, what will happen is you will be able to give access to education, information, treatment, rehab, all those facilities, counseling, which Celeste talked about. As a result, people don't do those negative things. They don't actually commit crimes. The families can be integrated. They can get back onto jobs. You can have OST delivered. That's the actual evidence. So there's no reason to feel that it won't happen here. Evidence which is available elsewhere should be used in India and Pakistan and the region. And I think we should be bold enough to say that we can implement policies better in these countries than elsewhere. Why should we be afraid of things going wrong? Actually, things have gone wrong because we have criminalized drug use. Let's be very clear about it. And the Global Commission is very clear. I also represent them. We want decriminalization of use and possession. And that should be our long-term aim. Thank you,
Anand, for that insightful answer. I want to thank all the speakers and the panelists for their valuable contribution in this session. It really was a special time, and I know it's a holiday weekend in India, so thank you again. I also want to thank all the participants, and we hope that this session really has been helpful and interesting. I think it really highlights the challenges that we face when providing services for key populations and the need to tailor them. Like for women who inject drugs, I think Celeste brought up these issues that they generally tend to be left out, but the larger societal and the stigma issues, as well as the legal complications of delivering services to key populations in the region. I want to thank all the participants who sent questions during the discussion, and we also encourage you to share the recordings of this session with other people whom you think might be interested. They will soon be available on the IAS Educational Fund's virtual platform, and it will be free of charge, and anyone can join the platform anytime to watch replays of the session. I think there was a lot of important and pivotal information and that could help inform program design. We also want to remind you that there is a networking session that's planned for 6:45 p.m. today. So those of you who have registered, we look forward to seeing some of you at that networking session. The register link has also been shared in the chat box, so please feel free to click on that and register for the networking session. The last thing I want to also remind you is that there is another session in 30 minutes, which is the fourth and final session of the symposium, which will focus on innovative preventive and treatment for both HIV and tuberculosis. And you can use that session link for session 4 from the homepage of the virtual platform to log into that session. And last, but probably most important, is please feel free to leave an evaluation survey at the end of this meeting and tell all our speakers and panelists how fabulous they were and how much you enjoyed this session. You will also receive an email on Monday requesting you to fill a survey to evaluate the symposium as a whole. What really worked, what could we have done better, and how do we actually make this better and more useful for all of you as participants and for the community in general. And even if you happen to miss this link, please feel free to email us anytime at iasedu@iassociety.org. Thank you all. Take care of yourselves and stay safe.